This is JAPI, and welcome to JAPI Podcasts. I am Dr. Mangesh Tiwaskar. I am the editor in chief of Journal of Association of Physicians of India, that is JAPI. Welcome to the JAPI podcast of April issue, JAPI Volume 72, Issue 4. This issue of JAPI has some really interesting articles, including 7 original articles, 2 review articles, one unique position statement, and also one consensus statement. There are also 3 unique case reports, one pictorial CME, and 3 letters of correspondence. Let us discuss them in brief here. The first original article is on fixed dose combination of canagliflozin and metformin as an adjunct to diet and exercise in Indian adults with type 2 diabetes mellitus. Results from the multicentric open label single arm phase 4 study by Mohan Magdum et al. This prospective multicentral open label single arm phase 4 study includes Indian patients with type 2 diabetes aged 18 to 65 years, inadequately controlled on diet and exercise. Patients received Cana Met 50 by 500 and 50 by 1000 milligrams immediate release fixed dose combination, that is FDC, twice daily for 24 weeks. The primary endpoint was safety assessment, including adverse events, that is AEs, and serious adverse events, that is SAE. The secondary endpoints included change in the HbA1c from baseline to week 12 and 24. The trial enrolled 276 patients, of which 114, that is 41.6% patients, had more than one treatment emergent endpoint, along with 29, that is 10.6%, were related to the study intervention. The most common treatment emergent adverse events were dyslipidemia 4.7%, pyrexia 4.7%, genital infections 3.3%, hypoglycemia 3.3%, and urinary tract infections 2.6%. 3, that is 1.1% patients, had serious TEAEs, including urinary tract infection, diabetic ketoacidosis, COVID-19 infection, and prostatomegaly. And all cases were resolved. Importantly, no deaths were reported. The mean change in the HbA1c from baseline was minus 0.92 and minus 0.93% at weeks 12 and 24, from an average of 8.4 at baseline to 7.5 at week 12 and 24 respectively. Another important finding was that 27.8 and 34.3% of the patients achieved HbA1c of less than 7 at weeks 12 and 24 respectively. To conclude, the study demonstrates the safety and efficacy of Cana Met FDC in Indian patients with type 2 diabetes in manageable side effects and no related reported deaths. The next original article is titled Effect of Alpha Blockers on Hand Grip Test, Response of Diastolic Blood Pressure in Hypertensive Benign Hypertrophy of Prostate Patients in Therapeutics Clinic, Kolkata, a cross-sectional study by Sambhu Samrat Samajdar et al. To give our listeners a background of this simple yet commonly used test, the isometric hand grip, that is IHG test, which is commonly used to detect sympathetic autonomic dysfunction. Participants were directed to exert their maximum brief compressive force with their right hand on 3 separate occasions and maintain it for a duration of 3 minutes. This was followed up by checking of blood pressure to evaluate the sympathetic function. The study conducted was a cross-sectional observational study. The objective was to investigate if there is any distinction in the blood pressure increase during the hand grip test between the individuals with essential hypertension taking tamsulosin compared to those taking prazosin. As we know, tamsulosin is used for management of symptomatic benign prostatic hyperplasia and acts as an agonist of alpha 1 adrenergic receptors, while prazosin used as an antihypertensive drug which acts as an alpha 1 receptor blocker. The study enrolled 50 subjects receiving tablet prazosin and 47 subjects receiving tablet tamsulosin who were asked to undergo an IHG test. Pre and post test blood pressure was recorded for both the groups, and the difference in the diastolic blood pressure, delta BP, was compared between groups and their respective baseline values. Results were as follows. Subjects on the prazosin arm had a baseline mean diastolic blood pressure of 83.62 plus or minus 9.01 millimeters of mercury, whereas in the tamsulosin group, it was 83.81 plus or minus 9.1 millimeters of mercury at the baseline. After completion of the IHG test, the mean diastolic blood pressure was found to be 93.98 plus or minus 9.13 in the prazosin group with p-value of 0.92 and 101 plus or minus 12.05 in the tamsulosin group with a p-value of less than 0.001. The change of delta diastolic blood pressure in the tamsulosin group was significant, but the prazosin group showed an insignificant rise in the diastolic blood pressure. The study also showed the blood pressure changes during the hand grip test, while significantly less in the subject taking prazosin than in the subjects with no treatment. They further suggested blood pressure elevation with the prazosin was markedly suppressed due to the blockade of the post-junctional alpha adrenergic receptors by the drug. Such a response is less likely with tamsulosin because it is more selective alpha 1 receptor blocker, which is predominantly present in the prostatic tissue. In conclusion, prazosin, being less selective than tamsulosin in terms of alpha 1 receptor antagonism, shows suppression of blood pressure during the hand grip test. Tamsulosin demonstrates higher selectivity for prostatic receptors while showing minimal affinity for the vascular receptors. As a result, it impacts on blood pressure and is expected to be minimal during the hand grip test, and it is unlikely to impact the antihypertensive effect of other agents. The next original article is titled Comparison of Insulin Sensitivity in Subclinical and Overt Hypothyroidism by Anusha Pini et al. This paper aimed to assess the association of thyroid hormone levels with insulin sensitivity in the patients with subclinical and overt hypothyroidism. This study was designed as a cross-sectional case control study, observed the association of thyroid hormone levels with insulin sensitivity in patients with subclinical hypothyroidism and overt hypothyroidism as compared to their age-matched controls with euthyroidism. The thyroid profile status, fasting blood sugar, and triglyceride levels and basic anthropometric measures were measured. Fasting insulin level and the quantitative insulin sensitivity check index, that is QICI, was calculated as surrogate indices for assessing insulin sensitivity. The QICI index was measured using the calculation including the fasting insulin and the fasting glucose. A value of more than 4 was normal, and reduction in the value indicated a decline in insulin sensitivity. The result of study showed both T3 and T4 were significantly decreased, p-value less than 0.05 in overt hypothyroidism. TSH was significantly higher, p-value of less than or equal to 0.005 in overt hypothyroid cases and in subclinical hypothyroid groups. Insulin levels were found to be significantly increased, p equal to 0.038 in patients of subclinical hypothyroidism as well as those with overt hypothyroidism when compared with the age-matched euthyroid controls. Insulin sensitivity index was comparable among the subjects of the three groups. In the present study, TSH correlated to triglycerides to certain extent. Though there were subjects with varying TSH values, there was no significant correlation between TSH and HOMA-IR in the present study. In summary, this negative study suggests that subclinical hypothyroidism and overt hypothyroidism had high insulin levels but without statistically significant association with insulin sensitivity index (TWICI), indicating no significant relation between the thyroid status and the insulin resistance, an important negative correlation since both diseases are frequent in population. Our next original article titled Study of Oral Hypoglycemic Agent Induced Hypoglycemia in Type 2 Diabetes mellitus patients in Tertiary Care Center by Milind Gaikwad et al. This prospective observational study was conducted in the Department of Medicine at a tertiary care hospital in Western Maharashtra. Data was collected over a period of 18 months from indoor patients on admission having hypoglycemic symptoms with strict blood glucose levels of less than 70 on oral hypoglycemic agents. Patients on insulin were excluded from the study. There were 60 patients with hypoglycemia with mean age of 53.65 years and higher incidence of hypoglycemia in females 35, that is 58.3 compared to males. A total of 50, that is 83.3% study subjects had neurogenic symptoms like tremors, palpitations, sweating, anxiety, hunger, and paresthesia, and 59, that is 98.3%, had neuroglycopenic symptoms like confusion, cognition symptoms, weakness, seizure, or coma. Most of the study subjects were on multiple pills. 30, that is 50%, followed by 24, that is 40%, were on the fixed dose combinations, and 6, that is 10%, were on single pill. The most common class of the drugs which caused hypoglycemia are sulfonylureas and glinides. In renal function tests, 26 patients had raised creatinine with GFR of below 60, and patients had an average creatinine of 1.5 milligrams per deciliter, that is GFR of 42 ml. 8 patients who expired were due to complications of hypoglycemia. 5 subjects developed hypoglycemic encephalopathy or hypoglycemic coma, and 3 patients died of aspiration pneumonia. There was statistically significant difference between the outcomes, that is discharge or death, and urine protein creatinine correlation, that is UPCR, deranged liver function, that is serum albumin liver enzymes, P less than 0.05. However, there was no statistically significant difference between the outcome, that is discharge or death, and mean age, gender, mean duration of diabetes, Glasgow Coma Scale scoring, and drug type of the study subject, where P is more than 0.05. Conclusions: the risk factors for hypoglycemia were middle aged patients. Females were at a higher risk of hypoglycemia than men. Hypoglycemia due to OHAs is known to have a recurrence of hypoglycemia due to the long half life of the drug. However, the patients who were hospitalized were well monitored and did not have any recurrence of hypoglycemia. Deranged liver functions or raised UPCR have higher mortality after OHA induced hypoglycemia. The message from this study is clear that use of sulfonylureas can result in hypoglycemia, and we must be aware of the patients who have hypoglycemia with elevated enzymes or raised UACR since they have higher mortality. On to the next study, which is about often neglected problem, hypogonadism in diabetes mellitus. The study titles Androgen Deficiency in Aging Males, Adams score as a predictor of total testosterone levels in type 2 diabetes mellitus patients, a prospective cross-sectional study by Swaraj Wadankeri. This single center prospective cross sectional epidemiological study in 250 male individuals with type 2 diabetes, Adams questionnaire, and serum total testosterone levels were analyzed for correlation and to evaluate the concordance and dissimilarity between Adams score and testosterone levels during insights into the Adams predictive ability for the testosterone levels. The mean age of the study population was 49.1 plus or minus 7-8 years. The mean duration of diabetes was 6.2 plus or minus 5.1 years. 27.6% were diagnosed to have hypogonadism, while 72.4% were eugonadal. The mean age was 51.1 and 48.4 years in the hypogonadal and eugonadal cohorts, respectively, P less than 0.02. The mean testosterone test in the hypogonadal cohort was 220.6 plus or minus 61 nanograms per deciliter, and in eugonadal cohort was 475.4 plus or minus 152.9 nanogram per deciliter, P less than 0.01. The mean body mass index in hypogonadal cohort was 26.5 plus or minus 4 kilograms per meter square, and in the eugonadal group was 25.2 plus or minus 3.6 kilograms per meter square, P less than 0.02. The Adam questionnaire included 10 simple questions as follows. Do you have decreased libido? Do you have lack of energy? Do you have a decrease in the strength of endurance? Have you lost height? Have you noticed a decrease in enjoyment of life? Are you sad or grumpy? Are your erections less strong? Have you noticed a recent deterioration in the ability to play sports? Are you falling asleep after dinner? Has there been a recent deterioration in your work performance? A positive Adam test is considered if patients answered yes to any of the sexual questions, such as decrease in the libido or strength of erections, or any other three non-specific questions, including fatigability, decrease in the muscle strength, mood changes, or loss of height, or if patient gives an affirmative answer to questions 1 or 7 or any three questions if considered positive as an Adam score. Chi-square test analysis established a strong positive correlation between the positive Adam score and hypogonadism, P less than 0.011. Of the 69 hypogonadal subjects, 84.05% had positive Adam score, yielding a sensitivity of 84.05% in detecting hypogonadism with specificity of 32.04%. Therefore, the Adams questionnaire is a practical and cost effective initial screening tool for identifying symptoms suggestive of testosterone deficiency. It has high sensitivity in identifying men with hypogonadism, while caution must be in place as it has a very low specificity. In resource poor settings, Adams scores should be clinical marker of hypogonadism. It also suggests that a holistic approach, considering the combination of the symptoms and responses from the entire Adam questionnaire, may provide more reliable indication of testosterone deficiency in particular diabetic population. Additionally, a large-scale studies are needed to confirm these findings and validate the utility of Adams questionnaire in diverse population. Impact of oral nutritional supplementation in chronic kidney disease patients on maintenance hemodialysis, an open label single arm study among the Indian patients by Arun Shah et al. This was a 3 months prospective open label single center study. Eligible participants supplemented their regular diet with one sachet, that is 40 grams, of oral nutritional supplement powder twice daily for 90 days. The study efficacy endpoint were mean change in the acute phase protein, that is albumin, and pre-albumin, anthropometric measurements like weight, body mass index, and triceps skin fold thickness, hand grip test, hemoglobin, total ion binding capacity, that is TIBC, potassium, and phosphorus levels. The malnutrition score, modified subject global assessment, that is modified SGA, malnutrition inflammation score, that is MIS, and nutritional status were also assessed. The oral nutritional supplement was scientifically designed with high protein, that is whey protein isolate in primary source, low glycemic index, and energy dense formula with added medium chain triglycerides and low potassium and phosphate levels. Patients were instructed to consume one sachet, that is 40 grams, of oral nutritional supplement powder twice in a day for 90 days. One serving of 40 grams was reconstituted in 180 ml of plain water. The study population comprised 36, that is 42.9% men, and 48, that is 51.1% women, with a mean age of 54 years. Serum albumin, prealbumin, hemoglobin, phosphorus levels remained stable throughout the study period. The change in the weight, BMI, tricep skin fold thickness, hand grip strength, and the total ion binding capacity of the overall study population was clinically significant at the end of the study. At the end of the study, there was a significant improvement in the SGA and MIS scores. Further, there was a significant improvement in the nutritional status as demonstrated by an overall intake of calories, proteins, carbohydrates, and fats. Conclusions: protein energy malnutrition is a strong predictor of morbidity and mortality and poor outcomes in CKD patients. A scientifically designed formula in accordance with the KDOQI standards was able to improve the nutritional status, overall body composition, sarcopenia, quality of life in the CKD patients on the MHD. The positive findings of our study support the ardent recommendation of oral nutrition supplement for the CKD patients undergoing MHD and may convert the catabolic effects of MHD to anabolic state. Our next article is an epidemiological study entitled Assessment of Epidemiology and the Clinical Profile of Psoriatic Arthritis Patients in India by Raj Agrawal et al. Their group conducted a retrospective observational study of patients diagnosed with psoriasis who fulfilled the criteria of psoriatic arthritis, that is CASPAR criteria. Patients were included from rheumatology outpatient department of a tertiary care hospital in Mumbai, India. The outcomes included demographic and the clinical profiles of the patient, patterns of joint involvement, and comorbidities associated with psoriasis. Of 60 enrolled patients, the mean age was 51 years, and there was a higher proportion of females, that is 62%. 40 of 60 patients with less than 5 joints had associated comorbidities like diabetes, hypertension, dyslipidemia, ischemic heart disease. Psoriatic arthritis occurred in 41 patients with highest occurrence in the age group of 30 to 50 years, that is 53.3%. A majority of the patients with psoriatic arthritis developed it within 2 to more than 5 years of psoriasis occurrence. In terms of the pattern of involvement, 43% were symmetrical arthritis, 16% had spondyloarthropathy with polyarthritis, 15% had asymmetric oligoarthritis, and one patient had arthritis mutilans. There was no significant correlation between the occurrence of psoriatic arthritis and comorbidities, as well as the duration of psoriatic arthritis and the number of joints. Pitting and enthesitis were most common morphological changes noted in almost half the patients. This study provides an overview of epidemiological and clinical characteristics of the psoriatic patients in India. These patients also fulfill the findings which would be useful for the early diagnosis of psoriatic arthritis and could also help clinicians and the dermatologists in the assessment and the progression and the treatment of psoriasis into psoriatic arthritis. An interesting review article in this issue is on cilnidipine, a dual L and N type of calcium channel blocker in the management of hypertension by Ketan Mehta et al. I am happy to be a second author in this article. Calcium channel blockers are widely used as antihypertensive agents due to their effectiveness in reducing blood pressure, along with their good tolerability and evidence of reduction in hypertension related to the cardiovascular and renal diseases. Cilnidipine, a unique dihydropyridine calcium channel antagonist, exhibits a potent inhibitory action on both N type and L type voltage gated dependent calcium channels. With excellent oral absorption, a prolonged duration of action, it demonstrates a significant antihypertensive effect. Cilnidipine also has got a pleiotropic benefits. It is found to have renoprotective, cardioprotective, and neuroprotective effects in the preclinical and clinical studies. It effectively reduces blood pressure, both systolic and diastolic, while providing renal, neurological, and cardiovascular protection. Unlike L type calcium channel blockers, cilnidipine does not increase pulse rates and is associated with reduced occurrence of pedal edema. Cilnidipine is an effective treatment choice for individuals with mild to moderate essential hypertension, whether it is administered alone or in conjunction with other treatment modalities. The second review article in this issue is on exploring the labyrinth imaging in systemic vasculitis by Tejinder Kaur et al. Systemic vasculitis is an immune mediated group of disorders broadly classified based on the involved vessel type. It has a myriad of clinical presentations, including the challenge of timely diagnosis and management. Thus, imaging has taken a center stage in the diagnosis of these disorders as there is a lack of definitive clinical diagnostic markers. Various available imaging modalities can be used for the diagnosis and follow up on these patients. The coronavirus disease 2019, that is COVID-19, has added a new dimension to the already existing problem of vasculitis. The virus has shown a great affinity for the vascular endothelium, leading to multisystem organ vasculitis. There has been spikes in vasculitis during the COVID-19 pandemic, thus necessitating the more research and studies in the field for a better understanding of the disease. Various imaging modalities have been highlighted with their benefits and limitations in the vasculitis subjects, including ultrasonography, contrast enhanced ultrasound, CT scan, CT angiography, DSA, MRI, and MI angiograms, along with PET scan. This review summarizes the various imaging spectrums of individuals, those who have got systemic vasculitis, amongst with new addition of COVID-19 related vasculitis to be already a long list of the causes of vasculitis. An important position statement has been published in this issue, and I strongly recommend all the physicians to read this. It is titled Indian Perspective on De-escalation of Dual Antiplatelet Therapy to Single Antiplatelet Therapy Study, a knowledge, attitude, practice study along Indian interventional cardiologist by Jagdish Chandra Mohan et al. The study indicated that more than 90% of CAD patients received dual antiplatelet therapy immediately after the PCI. About 115 of the respondents, that is 55%, reported using calculator based scoring for evaluation of the bleeding risk in the patients on dual antiplatelet therapy for the management of acute coronary syndrome in post PCI patients. Regarding the usual duration of dual antiplatelet therapy post ACS, nearly half the respondents, that is 94, that is 45%, said that 6 to 12 months is the usual duration of dual antiplatelet therapy in post ACS patients, followed by more than 12 months, that is 94, that is 45% of the respondents, and 17 of the total respondents reported it as 3 to 6 months. A total of 128 of respondents strongly believe that balancing bleeding with the ischemic risk influence the choice of the antiplatelet agents when treating the established coronary artery disease. As per International Cardiologist Survey, the perfect de-escalation time frame for Indian coronary artery disease patients with high risk of bleeding is up to 3 months, 35.9% with p-value of less than 0.01. 6 to 12 months from the medium bleeding risk, that is 48.8%, with p-value of less than 0.001, and more than 12 months for the low risk of bleeding patients, that is 65.6%, p-value of less than 0.01. Regarding the single antiplatelet therapy, almost one third of the respondent, 65, that is 31.1%, reported that they have been prescribed antiplatelet therapy other than aspirin in 20 to 40% of their single antiplatelet agents, and these patients were eligible patients for the further antiplatelets. Furthermore, 33% of the responders said that they preferred to prescribe clopidogrel in 50 to 70% of single antiplatelet eligible patients, while 30.5% prescribed clopidogrel in 25 to 50% patients. 25.4% prescribed less than 25% prescriptions of associated clopidogrel. Mostly, atorvastatin and clopidogrel is the most preferred combination with single antiplatelet therapy, primarily for the management of coronary artery disease among the majority of the interventional cardiologists. 33% with 95% confidence interval of 1.97 to 2.4 with p-value of less than 0.001. The study respondents also indicated a need for the Indian specific guidelines on de-escalation from dual antiplatelet therapy to single antiplatelet therapy in coronary artery disease management. To conclude, the in-depth study indicated that the majority of the coronary artery disease patients received dual antiplatelets immediately after PCI. The perfect de-escalation time frame for the Indian CAD patients with high bleeding risk is up to 3 and 6 to 12 months for medium bleeding risk patients and more than 12 months for low bleeding risk patients. One third of the respondents used clopidogrel as an antiplatelet agent in 50 to 75% of single platelet therapy eligible patients. Atorvastatin plus clopidogrel is predominantly the most preferred combination of statin and single antiplatelet therapy for the management of coronary artery disease. This extensive statement does call for more Indian data and for setting up an Indian guidelines for de-escalation of antiplatelet therapy. The following consensus statement is on fortifying micronutrient supplementation in India, expert consensus by American College of Physicians India chapter by Bansi Sabu et al. Micronutrients play a key role in human health, being involved in energy metabolism, immunity, cellular functioning, growth, and development. Micronutrients play a key role in human health. Deficiencies in micronutrients occur in individuals of all ages due to several factors, including inadequate diets, diseases, overweight, and obesity. Guidelines from ICMR, that is Indian Council for Medical Research, National Institute of Nutrition, that is NIN, and expert group on nutrition requires Indians to have specified recommended dietary allowances, that is RDA, for macronutrients and micronutrients. In addition, a healthy diet is crucial for overall health and should be the first step towards addressing micronutrients deficiency. When diet is inadequate, micronutrient supplements can provide excellent choice for the compensation. An Indian expert panel of Indian doctors, including those affiliated with American College of Physicians, were involved to develop a pathway towards micronutrient supplementation among the Indian population. This consensus statement recognizes that different populations have varying needs for specific micronutrients, and it ensured adequate intake of such micronutrients can improve the health outcomes. The panel provided recommendations of dietary practices and micronutrient supplementation when diet is inadequate. Addressing micronutrient deficiencies at the primary care level can prevent chronic deficiencies and their consequences. This consensus statement can serve a pointer and a primer for physicians to monitor and address deficiencies and thus help individuals to maintain their health. Thank you for joining JAPI Podcast.